Welcome to Healthcare IT Today. I'm John Lynn, together with my colleague and friend, Colin Hung. The world of technology and healthcare, ever-changing in new and novel ways, and that's why we love this stuff. So join us as we discuss the latest healthcare and health IT news, meshed together in new ways, which help generate ideas and new perspectives. Plus, we'll have a little fun along the way. On today's episode, we'll be looking at the permanent changes to healthcare because of COVID-19, which I don't know if there's anything fun about COVID-19, but at least we're here doing the best we can to help. So, also, today's episode is sponsored by HP, the leader in the world's most secure and manageable PCs. Learn more about HP's Healthcare Edition products at hp.com/go/healthcare/US. And be sure to follow the show on Twitter at the hashtag HITSM and our personal accounts at TechGuy and at Colin_Hung. Plus, check out our 13 years of health IT blog content at healthcareittoday.com. Are you doing all right, Colin, amidst the COVID-19 crisis?
Yeah, by the time this episode airs, I really sincerely hope I'm not on day 30 of self-isolation or stay-at-home warnings, but we very well may be. So it's pretty nutty out there, but it's doing well. Thankfully everyone's healthy. Nothing, nothing more than just inconvenienced, which I think is doing pretty well.
Yeah, I mean, the reality is we're all going to be impacted for months and even years after this is the impact. So that's why it's fun. Let's do a prediction of what COVID-19 how it's going to impact healthcare.
Yeah, and that's really the heart of the first questions, right? Or the topic of today is, what has changed because of COVID-19, and is that change permanent? And we were talking before the show started about one of the things that you're pretty adamant on, which is, of course, the HIPAA changes and the rollback that has happened. I don't know, you want to maybe explain that, John, and then why you think it actually won't be permanent?
Oh, you let him in on my secret. But no, I think it was wise of OCR to do what they call an enforcement discretion, which basically just says, I'm not going to come after you for HIPAA violations during this time period. And they were actually pretty specific with it and said it has to be telehealth related. It's not a HIPAA exemption from everything. It's just for telehealth, telemedicine. And they made it pretty clear that there were certain things that were okay. For example, FaceTime and Skype, which is encrypted and it is point-to-point with a user authenticated connection between two people. That was part of their enforcement discretion, and it was going to be allowed as part of it. And they won't come after you with HIPAA penalties and HIPAA violations and other sorts of penalties for an organization. They did also make it clear that doesn't apply to like YouTube Live or Facebook Live or TikTok or any of those public facing platforms that don't require authentication, don't really use even security or encryption, because it's meant to be public. So, that's the change. And it's a good change because it also applies to secure text messages through WhatsApp and other, iMessage and other things like that, where it's like, okay, now a doctor can communicate with another doctor and not have to worry about that communication somehow violating HIPAA. So I think it's a good change for now so that we can facilitate the needs of communication, especially as we're all, holed up in various houses and other places. So I think that's good, but I don't think it's permanent. I think that they'll roll it back. And the reason I think they'll roll it back is there are HIPAA compliant solutions that are available that people could use. And I think the only reason they offered enforcement discretion is they didn't want to force people to have to implement those right away. But in the future, I think they'll say, yeah, well, now you have time, so implement it the right way.
Interesting. I'm kind of hoping it's permanent, but I can see your point. I just think that those other tools, the FaceTimes and those other ones, but they're so quick to implement and they achieve the goal of what most people want, which is, look, if I need to just check in with a patient to get their temperature or just check in with them for 5 minutes, it's a really easy tool. They have it, I have it on my phone, it works. I think some of the challenges that we're seeing of some of the other full-on telemedicine and telehealth applications is, of course, it's not as ubiquitous, it's not so universally known how to use them. they're a bit clunky. So if anything, I think they've let the genie out of the bottle in the sense of, wow, like these tools are so much easier to use. Why don't we just use this one rather than having to go through these other products? Not to say those other products are all bad. I'm sure there's some good, easy to use ones, but you know, this was implemented in a matter of hours, not days and weeks, which makes you kind of scratch your head and go, what is it about those other ones that make it so complicated? And are they meeting, really matching a need that's much greater? So anyway, I'm hoping it's permanent, but I agree with you, it's probably not, because I think the risk of having the data exposed is too high, and that's something they will have to roll back.
Yeah, I mean, it would be nice if it was permanent, and because they are so easy, and it's a really good question about why aren't the others easier. But I think it gets really tricky when you start thinking of things like e-discovery and why wasn't this documented in the EHR, and what's the legal health record? Is it the text message that you send through iMessage? And if that's true, then maybe I need to look through all your iMessages, and then it opens up all sorts of new privacy things. So yeah, I mean, I just don't think it will continue. What I think will continue, though, is that organizations want to connect with you digitally, and patients are going to say, hey, you did it during the crisis. Why aren't you doing it now? And so I think organizations are going to have to find a telemedicine solution that is HIPAA compliant, that provides that same functionality that they may have been doing over Skype or some other tool, but that is HIPAA compliant. In fact, Skype offers a HIPAA compliant version as well. But you know, like, so I think they will do it. And luckily, that was one of the other big changes that I actually think will be permanent, and that is the reimbursement of telehealth. And so that is a big change that has happened because of COVID-19. And in short order, I mean, I know people who've been working on it for a dozen years and trying to get telehealth reimbursed. It's still not fully reimbursed the same way an in-person office visit is, but at least they're paying for it, and we can address the payment disparity as well. And I think that will be permanent, and that will be a change that will be a good one for healthcare.
No, I agree with you on that one. I like the fact that they've increased the billing possibilities, that it can be done through telehealth. I think that's needed. I think the whole industry obviously is going to get a boost because of all of this, and we talked about it in our last episode. But yeah, I mean, I'm hoping this one is permanent. I think it will be, because there's no point in rolling it back. It's not like it's hurting anything. If anything, if some organizations choose not to use telehealth, they just won't use those codes, right? But they're there and the billing is there. I don't think it's something they're going to roll back just because the crisis is over. So I think those are definitely going to be things that are going to be with us for going forward, which is fantastic.
Well, and it'll need some evolution as well, because I mean they rolled it out really quick, and it was good. I mean, credit them; they should roll it out quick. But the problem is there's a lot of nuance there that wasn't considered, and I think we're going to see it even more so when it comes to asynchronous telehealth. And how do we reimburse for asynchronous telehealth, which is a text message between your doctor, or a portal message between your doctor, or some sort of communication by text? That is work for the doctor, but our system doesn't have a good way to pay for that right now. We've started to see some remote monitoring and kind of asynchronous telehealth communication reimbursement. So they've waded into those waters, but it's not fully developed. And if we expect doctors to text message with us and provide care that way, then we're going to need to figure out a way to reimburse for it. I think many organizations would say value-based care is the right model, because then the doctor's like, okay, I'll just text all I need to, right? And the patients will be happy to text with them because they're like, I need to ensure that they're healthy. It turns out we've learned over time that most patients, aren't going to bug the doctor if they don't have to. In fact, most of us don't want to text our doctor, because if we text the doctor, we're admitting that we have some problems and need some help. And so it doesn't get abused the way some people thought it might. Or the people that do abuse it are probably abusing you other ways, by calling in, by showing up at your office, all of those other things. So, but even that, with that said, we still need to pay these providers, these clinicians who are answering the asynchronous telehealth. And right now, the system doesn't do a good job of that.
The one thing I will say that's sort of interesting I don't know how you address it, is do you get to bill for an AI chatbot conversation,
Mm.
right? Like you think about that and you go, well, this thing is, some of these AI chatbots that have come about because of COVID-19 are helping you triage to determine whether or not you should go to the ER or just stay at home, right? To me, that is a form of telehealth, but not being done by an actual clinician. It's done by an AI. So obviously, I think it would be horrible to charge for that, but it is providing a valuable service. So that's going to be an interesting question we're going to have to wrestle with, because a lot of hospitals and other organizations have implemented these chatbots just to reduce the volumes on their call centers and on their texting capabilities, and it is providing a valuable service. So it's going to be interesting to see whether that gets any funding or any love. Anyway, it's going to be fun to track that one.
Well, it's ironic too, because many of these organizations didn't implement those chatbots because it was killing their bottom line. And so, like, it's fascinating that now they have implemented them because they knew they needed to per the demand. And so, yeah, how are they going to recover from that and the damages? Yeah, that will be an interesting story to watch. There was
Yeah.
another change as well, where doctors are now under Medicare allowed to practice across state lines, which there has to be a whole history here that I don't fully understand with state medical licensure, and that doctors have to be licensed within each state. And Medicare said, okay, we're allowing you to practice across state lines. Assuming you have a medical license in another state that is comparable, you can practice within your scope. And but what's interesting is it was misread by a lot of people, because even though Medicare said that, it wasn't a blanket, hey, we have power, you can just go ahead and do this. Every state has to allow it as well, and only a certain number of states have. I would hope this becomes a reality and it becomes a federal law that just says, hey, state boards, you need to trust each other, basically. It was disgusting what a lot of telehealth and telemedicine companies were having to do with their providers, paying essentially useless money for all of these doctors to be licensed in 50 states. And, I would love to see that go away.
Yeah, it is. That is one of the changes that I hope gets, at least, if not made permanent, at least addressed after this crisis is over. Because it doesn't make any sense to any of us looking at a crisis like this going, why can't a doctor from the state next door who isn't suffering as badly come over and help? Why can't a nurse who's in a state that can only practice in a certain state can't come over? And why can't a clinician do that? It is pretty unbelievable.
Yeah, if it was Canada.
Yeah. Well, actually, that's a whole other one that we're struggling with up here. But because like you think about what's happened, right? Like they've basically, they've now increased the pool, if you will, of available doctors by making it potentially possible for someone from one state to go to and work in another, even remotely. They just man the telehealth or the phone lines, that's even a help, right? And now they've even asked, we know that New York State and other states have asked anybody who's recently retired, and then they got rid of the word recently and just said anyone who's retired, who's a former, physician or nurse, please come back and you're in, right? We need your help. The one step that they haven't taken yet, but I hope they do, is the one you just talked about, the international border. Like, why is it that we have Uber, drivers who have medical degrees, sitting on the sidelines when they potentially could be helping if they were trained in the UK or they're trained in Singapore or they're trained in other countries? You have potentially another resource that you can draw on. But just because they were trained and are waiting for some test or have to do 5 years of this or that here, you're not going to use them. To me, in a crisis situation, it doesn't make sense why that would still be there. So I'm just hoping that eventually the whole idea of just, if you're a trained medical professional, the barrier for you to practice should be lower. I mean, I think not in terms of your skill level, I'm just saying the licensing of it should be a lot less complicated.
Yeah, and I think you need to be more specific when you go international, because not all medical training is equal across the world. But within the U.S., even within the U.S., it's not equal, but it's pretty close, right? Because of the standards that are required. And I'm sure there's other countries that have essentially adopted what we're doing here in the U.S., and it's an equivalent degree. So that makes a lot of sense. It was interesting. I saw one story of a doctor who was retired and trying to go back, and he had, of course, 20 pages of paperwork to get re-licensed, or I forget the exact terminology, to get to be allowed privileges at the hospital again. I'm like, really? At this time, you have to go fill out 20 pages of information you probably haven't looked at in 40 or 50 years? Like, it's unfortunate, but I mean, I understand where they're coming from because those laws haven't been loosened, but it's a little sad, unfortunately. There was one other change that will be interesting, and that's the MIPS one. So MIPS was essentially delayed reporting for one more month. And then they said, we'll tell you what we're going to do for 2020 reporting later. I think that change is permanent. And I think we're going to see something really generous as far as delays on 2020 reporting as well. Oh yeah, and there was one other thing is if you don't report your MIPS 2019 data, you essentially get the automatic exemption and no penalties. And I think we'll see more of that, and I think it's the right thing to do. No one should be thinking about MIPS right now if they're busy dealing with COVID-19.
That is definitely so true. Hey, listen, if you're tuning in just now, you are listening to Healthcare IT Today with John Lynn and Colin Hung.
And today's episode is sponsored by HP, the leader in the world's most secure and manageable PCs. Learn more about HP's Healthcare Edition products at hp.com/go/healthcare/US. And be sure to follow the company on Twitter at HP. The best Twitter account you can get at HP, right? That's as
Just
simple
two
as it
letters.
comes.
That's it. That is.
I'm
That
jealous.
is. So let's get to our second topic, John, in the time we have left, and that is, given the COVID-19 pandemic, what has it, well, I think it's laid bare some of the gaps that we have in healthcare, and I think it's caused some permanent damage to the healthcare system. And so let's spend some time talking about that. What was the first one that you noticed, John?
Yeah, I mean, the first one for me was the lack of surveillance data that should be able to be provided from the EHR vendors. Why the Epics and Cerners of the world didn't hop on this and make something available that says, hey, here's all the data from all of our EHR software that says how many COVID-19 cases came in, how many people came reporting with fevers, etc. Why don't we have that data? I mean, healthcare interoperability has always been a problem, but guess what? Within Epic, they should be able to do this. And it's even Cerner, not to call it just Epic, but any of the EHR vendors should be able to do it. And I imagine a few of them could, but they just don't have the same footprint of Epic and Cerner. So it's unfortunate that that hasn't happened, and I think that's a huge gap. I think Arian Malik described it well in a tweet. He said, I'm never going to complain about a population health interoperability piece of MIPS from now on, or something like that. I was like, yeah, we're facing it and we wish it were there.
Yeah, that's definitely one of the areas that I think was exposed. The other one for me that was exposed was, I think we all like the thought of everyone being equal and first come first serve kind of mentality. But in a crisis situation like this, and what I'm referring to specifically is about the COVID tests, and not about getting it, but actually results from it. And to me, one of the things that we should be doing is prioritize whose results come back first. From having a test. And to me, what I'm talking about is really around healthcare workers. Those tests for the healthcare workers should be prioritized and done first because we need them to get back. Because if they're negative, they should be put right back and they need to get back to what they were doing, to taking care of patients. But we're hearing stories now of some people having to wait 2 or 3 days to get their results in the US, but in Canada, it's now up to about 6 or 7 days to get results back. And to me, to have someone out of circulation for 6 to 7 days, especially a healthcare worker or a first responder for that long is ridiculous, right? So I think one of the gaps that has been exposed to me is we need to prioritize the tests. not based on anything other than, are you part of the healthcare organization? Because if you are, you should get tested. Like, your test should be done first, and then you're right back into it. Because if you're positive or negative, that has implications. So to me, that's a big gap, and I don't know how to fix it. I just look at it and go, I can't. There's about hundreds of nurses that are right now in isolation because they don't know whether they have COVID or not.
Yeah, well, we shouldn't prioritize NBA players and senators over nurses and doctors. That's something we've definitely learned. I think Farzad Mostashari and some of the other people, I think Andy Slavid, some of their stuff has pointed out that even the test result itself, without more context, is not that valuable. So number of positives is great, but how much better would it be if we had number of positives and their age and what conditions they came in with and what comorbidities they had before and what so there's all of this other data we need. And they argue that the real problem was we didn't ask the right questions up front, and so we're not getting the data that we need now to be able to answer those questions. And I love that idea, and I think that's a gap that we've learned is we need to know what questions we need answered so that we can ensure that the data that's coming back from these tests is the data we need to be able to make educated decisions. Because if we found out that it was always people over 65 that were testing positive and they all had cancer or whatever it might be, in the next epidemic, then that would help us understand, oh no, we don't need to shut everyone down. We just need to shut these few people down or whatever it might be. So I think that was another gap, is designing what data was needed and will be needed to help us make better decisions. That's a huge gap.
Yeah, and just on what you just mentioned Farzad there, one of the things that I think is a piece of permanent damage caused by COVID-19 is I think we're going to see a rash of shutdowns of primary care physician practices. I think that area, and Farzad has really tweeted about this a few times and kind of raised the alarm bell to say a lot of these practices were running pretty close to break even already. And now with this shutdown and them having to maybe go and work at the hospital for a little bit, or just not being able to see patients, because they're shut down their office, but they're going to suffer as a business. And so there's going to be a lot of those primary care practices that won't reopen after this crisis is over, not because they don't want to, but because it just wasn't financially viable for them. The other worry that a lot of people have is they might decide, what, I'm better off working at the hospital. Right now is obviously crazy hours and not a great situation, but you know what, that's a lot easier. I didn't have to worry about financial stuff. I just, I go, I work, I help patients, and I'm done. So there's going to be some pretty big fallout and pretty big damage in terms of the primary care layer of healthcare. I don't think it'll return back to where it was pre-COVID.
Yeah, and I'm interested to see if private equity or hospitals and health systems just chomp them up at pennies on the dollar in order to acquire them. And in some ways, it's good because that will keep some of them open. But I think some of the rural ones, they're just going to suffer. I saw someone else mentioned that, yeah, primary care doesn't have anyone to cut. It's basically the doctor and the front desk staff, maybe a nurse in many cases. So there's no areas really to cut. And so it is unfortunate that we're going to see a lot of damage, but even the hospitals are suffering as well, since a lot of their money comes from these elective procedures, and that's going to be a problem for them.
Yeah, and that's another story that's been bubbling, now, and I think it will continue to bubble by the time this airs. And that is just the number of layoffs and financial constraints that hospitals are under because, yeah, they're not doing the revenue generation type of activities anymore. So we've heard stories about, some administration folks being laid off, and then even some nurses who practice in those specific areas are being furloughed. And it's a bit crazy to think about that. Like, why would healthcare shrink in this time? But there are some organizations who that's all the kind of services that they were providing, and that was what generating the revenue. And now that that revenue is not coming in, they're having to turn either to government sources for assistance, or they're having to shrink, which is kind of crazy.
Yeah, and I read a crazy article talking about the insurance company side of things, and you would think that payers would be suffering as well, covering all these people with COVID 19 and other coverage, but it turns out they're avoiding many procedures that are costly to them, and so they're saving money that way. They're not covering COVID-19 the way that they should, and then rumor is that payers are going to start charging more for premiums, and next year they're going to just basically make up for all their losses this year with higher premiums next year and create a better business. So I'm hoping some people are watching that and we can avoid that, because it just says something really awful about our system if payers are not taking some of the brunt of this and covering people the way they should be. So yeah, that's a scary gap as well.
Yeah, no, that is, and you're right. I mean, there hasn't really, the payers have been sort of the silent group in all of the COVID coverage. I mean, they're one of the groups that aren't talked about. Pharma is obviously front and center, and with the antivirals and all the potential cures and vaccines that they're working on and trying to help out. And then, of course, healthcare organizations being right in the middle of it. But the one group that has not said very much during all of this is the payers. And obviously, I think there's a reason for that. Mostly because they probably don't know what the heck's going on, and they're probably not covering as much as we think they are. So they probably are smartly remaining silent right now.
For their business, it's smart, but it really is unfortunate. I mean, we've heard from our cat walker, we've heard from our bank, we've heard from our pizza place, we've heard from our provider, and we haven't heard a single thing from the payer, and that's unfortunate.
Yeah, no, it's true. But well, I mean, hopefully, we come out. We're hopefully, turning the corner. Hopefully, we are going to come out of this better. And that, one thing I will say for sure is healthcare is once again going to be front and center of all the politics, all the business, all the funding. There's definitely going to be a lot of money flowing into healthcare. So whenever this ends, there's definitely going to be a lot of opportunity for people on the other side of this. If we can just get through this really tough time of staying at home and keeping others safe by being at home.
Yeah, and it's going to force us to rethink a lot of things, and in many ways that's good because healthcare needed some redesign. I'm not sure this is the method I would have chosen to do it, but it's certainly forcing us out of our shell and forcing us to look at issues within healthcare in a different way, and it will bring them to light. And I think when all is said and done, I think we'll be better. Our healthcare system will be better for it, although there's going to be some damages that are going to last, especially individually, to organizations and to patients that they're going to be lifelong.
Hey, on that positive note, let's end this episode. So thank you to all of you who tuned in to this episode of Healthcare IT Today. And thank you to HP for sponsoring today's show. You can learn more about HP and their Healthcare Edition products that were designed with clinicians in mind to streamline patient care and optimize clinical workflows at hp.com/go/healthcare/US. And to find out more details about our show, check out the programs page on healthcarenowradio.com. And share your voice and engage with the community at healthcareittoday.com and on Twitter using the hashtag HITSM. I'm Colin Hung along with my friend John Lynn. Thanks for listening and have a great week.